Hi, good morning. Welcome to today's Grand Rounds in Cardiovascular. This is a series in which we bring the multidisciplinary cardiovascular teams together and the latest innovations to our community. And we share these not only with the experts in the cardiovascular arena in the Ottawa region, but in fact across Canada. And so particularly welcome to those joining us from afar. And a warm welcome from my co-chairs, Dr. Vince Chan, Department of Cardiovascular Surgery, and also Dr. Rob Beanlands, Head of Cardiology here at the University of Ottawa Heart Institute. Just a few housekeeping aspects before I introduce our star attraction this morning, Dr. Stephen Bolling, is that to facilitate the interaction, please submit your questions using the Q&A feature throughout the lecture, which is on the bottom of your screen. And there will be also an opportunity for you to pose live questions at the end of the lecture. And you can use the hands up feature, and then you will be able to ask to join by unmuting your microphone by the moderator. But on the other hand, if you have any technical issues, please use the chat feature and you will be able to get some instant help from that point of view. We're absolutely privileged today to have Dr. Stephen Bolling as our featured Grand Rounds lecturer. Dr. Bolling is professor of surgery in the Department of Cardiac Surgery at the University of Michigan. And after completing his medical school at Michigan, he trained in general and thoracic surgery at the Johns Hopkins University. And what is probably not as well known is that Dr. Bolling, in fact, has a lot of Canadian connections. His uncle lives right here in Ottawa, and we're absolutely privileged to have him with us today. He joined the cardiac surgical faculty at University of Michigan, in fact, launched and directed one of the earliest multidisciplinary mitral valve clinics in the world. And he's been a pioneer and thought leader in mitral valve repair, particularly in patients with advanced heart failure ever since. More recently, he has also focused on the tricuspid valve, not only on the repair, but on possibility of novel device innovations. Yeah, he's also the director of Molecular Biology Laboratory at the University of Michigan, and his research in biology of the heart failure, particularly in terms of signaling challenges. He has authored over 350 peer-reviewed publications and holds numerous prestigious grants, including those from the NIH, American Heart Association, and biotech and device industries in innovation. Dr. Bolling leads and participates in many large clinical trials in mitral valve repair, and is a leading voice at major professional societies in advancement of the structural heart disease care. He's been a speaker in many international forums, and we're very proud of the fact that he has been an esteemed speaker in our Ottawa, Toronto Heart Summit, but most recently at the Heart Failure Society of America meeting, which we have turned 100% virtual. We were absolutely privileged to have Dr. Bolling to give an excellent update in the state of tricuspid repair in a session on structural heart disease that really was lauded by everyone. We therefore look forward today to Dr. Bolling's lecture at today's Grand Rounds entitled Transcatheter Tricuspid Valve Interventions, Myth or Reality. Steve.
Peter, thank you very much. And thanks, Rob. Thanks, Vince, from having me sort of virtually here in Ottawa. I do have connections with Ottawa and to Canada. I have dual citizenship right now. It's really a privilege to be able to speak to everyone. I am going to share my screen now. And we'll see. Does everybody see that? Peter, is that okay? Can we see that now?
Oh, yes. Yes,
great.
That's actually great. Perfect.
Fantastic. So I'm going to talk about transcatheter tricuspid interventions, myth and reality. And we're going to talk about a few myths and realities of the valve. So first of all, we're going to talk about tricuspid regurgitation, because everyone used to think that tricuspid regurgitation was not so bad, it was fine. But the reality is that FTR, or functional tricuspid regurgitation, really increases mortality. You will die earlier if you have tricuspid regurgitation. If you have your choice of having it, choose not to have it. And in fact, this early study in 5,000 patients by NASH shows that severe and, importantly, moderate TR increases mortality. This was again reconfirmed by Topilsky 10 years later that severe and moderate TR decrease survival and impart a mortality ding on the patients. Having TR is bad. It is not something that you want. Having TR is bad after percutaneous procedures as well, too. There's nothing magical about surgery or so on like that. And this is after mitral valve balloon valvuloplasty. If you have TR along with your mitral valve disease, you will die earlier than if you did not have TR. Even MitraClip, having TR and having a completed MitraClip is bad. It's a worse outcome if you have TR, even percutaneously. You can see severe and moderate TR is bad. In mitral percutaneous valve replacement, it's worse if you leave TR. Again, severe and moderate TR is bad and imparts a mortality ding on patients if you do a percutaneous procedure. And of course, this is not surprising. It has nothing to do with the mode of therapy that's delivered to the tricuspid valve. Having TR after heart surgery is bad. We've known that for years. And we know that more TR after surgery is more bad. The worse your TR is, the worse you do. So the reality of this is very simple. Moderate and severe TR is bad. It will lead to a bad outcome. It imparts a mortality ding on the patients. And not just the quantity of life is hurt, but the quality of their life is hurt. TR is bad. So how many patients actually have TR? We sort of think as practitioners, well, TR is out there, but it's okay. We'll give them some Lasix. They'll do well. We don't see too many patients with TR. That's incorrect. There are lots of patients with TR. About 20% of every patient we see with MR will have significant tricuspid regurgitation. And it really has to do with the anatomy of heart failure, the anatomy of mitral regurgitation. This is the normal anatomy relating the LV to the RV. The LV is sort of like a bullet, and the RV is a crescent around that. It's sort of like a donut with a croissant around it. Now, as the LV expands, whether it's for heart failure or the patient has mitral regurgitation, most commonly, that bullet expands. Now, the RV, of course, is attached to the LV and cannot stay motionless in space like this. That is not how the geometry ends up, but that RV is dragged around. Those points in space are pulled around in a math study called manifold geometry so that the RV looks like that. And you can imagine as the RV expands around the LV, the tricuspid valve is just pulled open. And in fact, what we see is 75% of the patients who have significant mitral regurgitation have annular dilation or shape changes of tricuspid regurgitation. 75% of them, even if they don't have TR yet, will have shape changes. However, tricuspid regurgitation is totally ignored. If you take a look at this, there's 1.6 million people in the United States with significant tricuspid regurgitation. You can see that the relationship between mitral surgery and tricuspid surgery is incorrect in the United States. We do about 60,000 mitral cases a year in the United States, and you would think that somewhere between 30 and 40,000 tricuspid regurgitation cases, but we do between 7,000 and 8,000 tricuspid regurgitation cases. TR is totally ignored. So the reality of TR is moderate to severe TR is bad, and that tricuspid regurgitation is completely ignored, and that's bad because it imparts a mortality ding on our patients. So does it matter if we repair tricuspid regurgitation? Well, if you look at the seminal paper in our surgical literature by Gilles Dreyfus, this was 15 years ago now published. He took 300 patients who he was there to do a mitral repair on. Almost all of them were degenerative disease. And the origin of their tricuspid was secondary MR, secondary to their MR. And if you look at these patients, of these 300, none of the patients had severe. Only very few of the patients had moderate MR, and most of them just had a dilated annulus. And how Gilles in this paper thought about a dilated annulus was he would take his hand, as you can see here, and place it through the tricuspid annulus. If he could get his hand through, he would repair it. Then he measured his hand and figured out that the corresponding diameter was about 4 centimeters, which is a funny way we've come up with 4 centimeters, but that's sort of the way we did. So he took these 300 patients and randomized them to either get or not get a tricuspid repair. And the results were 2 years later, if you had a mitral repair only and ignored the tricuspid valve, 50% of them went ahead and progressed their tricuspid regurgitation. Whereas if you did something to the tricuspid at that time, only 2%. So 50% move forward versus 2%. Overwhelming that TR does not go away after a mitral repair. We used to think that, oh gosh, we'll fix the mitral valve, the geometry of the LV and the RV will go back to normal, and the tricuspid repair, the tricuspid will repair itself. But in reality, it doesn't. It's like a broken rubber band that's already stretched. So if you take a rubber band and snap, 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 you can do it a million times as long as you don't break the fiber in the rubber. But if you actually take that rubber band and overstretch it, just like a tricuspid valve that's being overstretched because of the change in the geometry of the RV, and you let go of it, that rubber band is done. It is not ever going to come back to normal. And there's nothing more vexing to a practitioner to have a perfectly well done mitral repair and the tricuspid just keeps enlarging. Now you have a patient, you have to go back and re-intervene or they'll die. So does that make sense? It does make sense because late TR after MR surgery is almost always related to the annular size. The bigger the annular size is, the more TR they have. And if you think of it, it's just math. The normal tricuspid annulus is about 2.8 centimeters. If everyone takes a look at their own thumb and forefinger like this, that is the size of my tricuspid valve. It's really not very big. And you can see that one standard deviation is only half a centimeter. If you think of it then, 6 standard deviations, which is almost the entire population of humanity, falls somewhere between a 26 and a 31 size. And that, if you look at this data from Sugimoto, you can see that below 30, below 3 centimeters, there's almost no tricuspid regurgitation whatsoever. But if you get up around 4, you start getting obligatory tricuspid regurgitation. It's almost all based on annular size. As the RV pulls around, as the tricuspid annulus opens out, you unlock the tricuspid valve, you have no more zone of coaptation, and you just get TR. There's nothing magic or mysterious about it. It's just math. So if we look at the large surgical series of tricuspid repairs, this is Jim Gammey's series, where he talked about undersizing tricuspid valve repair. He used the 28 ring, and it's really not undersizing. It's actually just re-normal sizing. No human should have a 4 or 4.5 or 5 centimeter tricuspid annulus. That's just not a normal size. So putting a 28 ring on that actually just brings it back down to normal size. And you can see that his results in this first undersized trial were fantastic. All the patients had moderate to severe, and 1 year later, he had very little recurrence of tricuspid regurgitation. Are there other series in the literature that follows up? This is David Adams' series from Mount Sinai. He had 645 patients who we basically put tricuspid rings on, and they had far less TR recurrence. They had better RV function. They had no increase in mortality or permanent pacemaker rate. So the thing that scares surgeons about putting a tricuspid on is not so much the length of the operation, but it's the pacemaker ring. So what we did at our institution, and this came out last year in the JTCVS, was we had 262 patients that we put rings on exactly following the ACC/AHA guidelines. That means if you have moderate or severe tricuspid regurgitation and you're there in the heart, please fix the tricuspid. If you have less than moderate, mild or less, but you have a dilated annulus to 4, please put a ring on it. So we did 262 patients consecutively in a row. By those, we put a small ring on there. There was no mortality in this series, no tricuspid stenosis. Surgeons worry about that. The RV function was, of course, improved. And only 1% of the patients, one patient, really went on to severe TR, and there was a 2% pacemaker rate. So really, it's very, very safe to put a tricuspid ring on these patients at surgery, and it works. So the data from Jim Gammey's paper, from our paper, from Dave Adams, that's 1,000 patients treated exactly by the guidelines with a very low pacemaker rate and no increase in mortality. So if you look at from the surgical thinking, from the medical thinking and so on like that, the reality of tricuspid regurgitation is that moderate to severe tricuspid regurgitation is bad, that tricuspid regurgitation is ignored and that's bad, and that to fix TR is good. So what does this mean for percutaneous implications? What is this moving to the future? What is our success criteria and how can we help our patients? Because obviously we are ignoring these patients. They're not coming to surgery. Well, if you look right now at the percutaneous TR landscape, it's massive. There's thousands of different devices out there. Some have already fallen by the wayside, and they sort of fall into a number of different categories. One is the direct suture annuloplasty, which is sort of trying to recapitulate what we did in surgery in the older days. The second is a group of direct ring annuloplasties, which is trying to recapitulate what we do now in surgery, and then other things, and then finally valve replacement. And obviously, percutaneous devices don't have to actually look like what we do at surgery. They don't. If you think of it, does stenting a coronary artery look exactly what I do at bypass surgery? No, it doesn't at all. But physiologically, it serves the same purpose. So let's look at these. So percutaneous, not rings. If you see these devices, you look at them and you think, what? How could these possibly work? And if you see the upper devices putting, one single screw in the annulus and then pulling it to shorten up the AP diameter on the tricuspid valve, how could that possibly work? And if you look at these, this is what Vortec does. The problem with Vortec is that this looks very nice in a two-dimensional cartoon, but in reality, it's pulling out of plane. It's pulling like a triangle, and it's pulling in the wrong direction. And they've had difficulty. The amount of force that they have to pull on this device to actually shorten down the annulus actually probably pulls that screw out. And any device that has 1 point pulling is probably not going to be a great idea. The other problem with these devices is when patients come to us for a percutaneous device, they're at the far end of the bell curve. If you think of it, this is a group of patients with tricuspid regurgitation, then the massive, and now we're getting into patients who have severe tricuspid regurgitation, who have annuluses of 5 or 6 or 7 centimeters. And those patients are probably not going to be helped no matter what they have. This is, of course, the mitral line, which is being changed into the trial line. It was tried in the tricuspid and then probably didn't work as well. This actually tries to recapitulate a percutaneous Mackay, which was done at surgery. And we have to say this failed when, as surgeons, we were able to look directly at it. How could that possibly work if we're doing it by echo and fluoro imaging? They put these pairs of pledgets underneath the annulus and then pull the pledgets together, which sort of looks like a Mackay or a De Vega. Maybe it's a percutaneous De Vega if you put a lot of them in there. And you can bring down the annular circumference, which is, if you think, that's what a tricuspid ring does as well. And this was in their first trial, and they said, goal accomplished. And this is the problem with tricuspid thinking right now, the percutaneously. The goal accomplished is 10 square centimeters of an annulus. That's the annulus is still this big. You can almost get your head through it. And this is 1.5 square centimeters was brought down to after success in this. That is 400% larger than severe TR. Seriously, goal accomplished? No, I don't think so. You left the patient with severe TR, and the patients just don't do well. And if you look at this, this was a large review from last year from Jack, and it looked at patients who had already had severe TR. And the difference between surgery and medical therapy was not different, because the patients, by the time they have massive, severe TR, they have liver failure, they cannot fit their feet into their shoes anymore. Those patients have 1 foot in their coffin and 1 foot on a banana peel. And no matter what we do to them, it is too late. So we have to start thinking differently about percutaneous, because it's a myth that we can intervene on these patients with severe TR and make a difference to them. And I think in tricuspid, it's the parable of the parachute that we have to be aware of. And what this is I'll tell you, I'll do an experiment of whether a parachute is good or not for patients. And we'll take 100 patients, and on the left, we'll take 50 patients, and we'll give them a parachute in a plane, and they jump out and they float gently down to the ground, and they're okay. And then another 50 patients, we just shove out of the plane without a parachute. And of course, boom, they hit the ground and they're all dead. So 50 with a parachute live, 50 without the parachute die. And we conclude that parachutes are very good for jumping out of the plane, very, very good. But I'm going to do another experiment now. And I'm going to take 50 patients on the left, and I'm going to give them a parachute, but they can't pull a parachute before they're 5 feet above the ground. So they jump out, they pull a parachute at 5 feet above the ground. They still hit the ground at 200 miles an hour, and they're all dead. Even though they had a parachute, they're all dead. And I take another group and I just shove them out of the plane without a parachute. And of course, they hit the ground and they're all dead. And now we have an experiment that says parachutes make no difference. The 50 with the parachutes, they all are dead. And the 50 without the parachutes, they're all dead. So now we have two experiments, one saying that parachutes are good and one saying that parachutes are bad. How can those both exist at the same time? Well, this is the lesson, the reality that good therapy applied too late doesn't work. So when we think of these patients, we have to think of intervening earlier. Well, let's look at other types of therapy we've tried percutaneously. And we've tried, of course, edge to edge, which is a good therapy for mitral valve. But again, if you think of it, we suffer from the parable of the parachute in mitral clipping as well. That we had two studies, the COAP study, which showed definitely in mitral regurgitation, mitral clip helps. And then we had mitral FR, which said definitely it doesn't help. How could it be? Again, it's the parable of the parachute of coming to therapy too late. Well, let's look at tricuspid edge to edge. This is the real world experience with tri-clipping, with using the mitral clip coming into the tricuspid valve. It's somewhat difficult. The imaging is tougher from the TE because the right ventricle and the tricuspid is further away from the esophagus. And here, the results are bad. Even though the real world experience, if you say procedural success, 90% success, again, you see that the ERO that they left these patients with is severe TR. So that even though they were able to land a clip, the outcome in these studies in the real world are bad. And you can see that the mortality is 20% at 1 year if it worked. And if you had a procedural failure, it was even higher than that. So the outcome of these clips is not good. And so we now think there's this myth that the percutaneous TR goal is somewhat different, that, oh gosh, the patients feel better, or that we'll change the scale, that somehow intervening on these patients. We have to remember that the reality from large series is even severe TR, it's probably too late to intervene on the patients. Of course, there are other things going on. The Pascal may be thought to be better because it has paddles and it's soft and so on like that, and it's being tried in tricuspid. It has spacer. I think most of the problem with these patients is the imaging. I think there are percutaneous rings that are going to be tried in the tricuspid, and I think, at surgery, we obey Beyonce, we put a ring on it. And so I think there are percutaneous rings that will be on the market soon. The Cardioband, of course, has been used very nicely in the tricuspid. It's tough to image, and their functional improvement has been pretty good in these patients. They have better New York Heart Class, better 6-minute walk tests. But unfortunately, you can see that the septal lateral diameter of these is not significantly changed. They're still extremely large, and this predicts a failure. If you can remember back to the slide, if you leave that diameter above 30, you're going to have tricuspid regurgitation. So you have to bring that tricuspid valve down to this size. There's no tricking the anatomy, the geometry of the math. This is a device I'm quite familiar with. This is the millipede, which is being placed percutaneously in about 40 patients in the mitral position. We have 2 patients with tricuspids, so it's a very limited experience. But of course, these are brought down in size, and the long-term follow-up of these 2 patients who are now 2 years out has been good. It's just like putting a surgical ring on them. I think these things are how we're going to move to in the future. What about tricuspid replacement? Again, it's hard to image the leaflets in tricuspid replacement, which we've done at our place is a lot easier because you don't really have to see the leaflets, and there's a number of models to navigate, the Intrepid, the Cartier Q, which is now called the Evoke, the Edwards device, have all been tried in the tricuspid. The problem with that is just like in the mitral valve, the reality of ventricular geometry is that giant devices hurt ventricular geometry. And just like in the mitral valve, these devices are basically just a TAVR turned upside down so that a TAVR presses nicely against the calcified aortic stenosis, but there's no calcification in these patients with functional tricuspid regurgitation or in mitral regurgitation. And of course, they have to be giant. If you think of it, this is the normal size of my tricuspid valve, about 28 millimeters. These devices are 45, 50, 55 millimeters. That is the size of this coffee cup across that I'm now going to jack into your tricuspid annulus and make it big. And if you think that something the size of a Diet Coke can jacked into your ventricle is going to help your ventricular function, you are drinking the purple Kool-Aid of percutaneous therapy. That's just not going to happen. This is going to hurt these patients. And of course, the outcome in these patients who are now allowed to come to percutaneous tricuspid therapy with very bad RV function, and then on top of that, we hurt the RV function, these patients do very poorly. This is very analogous to when in my training, we would take a patient with bad MR and cut out their subvalvular apparatus because we weren't aware how badly that hurt them, and the patients would do horribly. So these devices are not quite ready for prime time yet. I think another myth I want to talk about is that the TR goal for percutaneous therapy is somehow different. That now Becky Hahn and the Society for Echo has somehow said that TR needs to be regraded. The TR grades are 1 through 4, and that we have now 5+, which is massive, and 6+, which is torrential, and I think there's going to be a 7+, which is tsunamic or something like that. The reality is that TR is bad. It's really bad. And that the biology of TR will not change with the method of therapy. So delivering the therapy by surgery or by transcatheter will not make any difference to the right ventricle and to the patient's outcome. A new grading method will not fool nature. So if we move a patient from torrential to massive and we say victory, that will not happen. That we know that patients, even when they have severe, from that study from Jack, 3,000 patients who have severe TR, it will really make no interventional difference. We need to move the patients down to less than moderate. They need to have mild, trivial, or no mitral regurgitation. This is what we have to do. So this is the traditional cardiac team. And I'm not making fun of any of the cardiologists, but it's over on the right. If you remember this movie, this was Maverick. We'll call him the cardiologist. He has all the patients. He's not collegial. He needs money, no teamwork, bad decisions. This guy's a stupid jerk about tricuspid patients. And over here is ICEMAN. Of course, he's the surgeon. He's cooperative, of course. He's brilliant, of course. He bails them out all the time, of course. He has team spirit. He's very handsome, but somehow he's an arrogant ass. If you remember who this guy is in the middle, that's Goose. He's the TR patient. He's caught in the middle and he died. And that's what happens to our TR patients. While we're fighting about what kind of intervention we're supposed to do on our team, this TR patient is going away from us. They now have liver failure. They come to us with a MELD score of 20 and an INR of 2, even though they're not on Coumadin and they can't fit in their shoes. We can't do that. We need to work together as a team. We need a structural team that thinks about these patients together. What we really need to have, the reality, is a sustained, meaningful reduction of tricuspid regurgitation. I think the tricuspid team of tomorrow is going to look like this. We're going to have cardiology, we're going to have surgeons at the table, and we need to have imagers and we need to have heart failure people all at the same table, all talking about patients at the same time. For us, I'm a surgeon. We work in our structural team, and a percutaneous approach and a surgical approach is all part of our tools in the toolbox that we're trying to serve these patients with tricuspid regurgitation. The reality is tricuspid regurgitation is less impactful on the patients, and therefore early intervention is probably warranted before the patients are away from us. Obviously, if we get to the patients and we hand them a parachute 5 feet above ground, we will have no change in their outcome. Moderate, severe, the reality is moderate and severe TR is bad. We will impart a mortality damage on our patients if we let them have moderate, severe. Moving a patient from tsunamic TR to just massive TR will not help their outcome at all. Massive, torrential, tsunamic is a silly way to think of it. So what is good enough for the patients, whether it's percutaneous or surgicals? We have to leave the patients with 1 or 2 plus. And the best way is, the best TR is no TR. If your patient has a choice, or you had a choice of how much TR you wanted, it would be 0, whether it's percutaneous or surgery. That's how we have to get there. Thank you very much for allowing me to talk. I'd be happy to take any questions. Rob, Vince, Peter, thank you again.
So, Vince, do you want to lead off there?
Absolutely.
While we wait for questions to come in?
Fantastic. Dr. Bolling, that was a fantastic talk. Certainly, you framed all of tricuspid valve disease and intervention in a very succinct way. And naturally, you know, in your capacity as a surgeon and innovator, it's quite unique to hear your insights. So give me some of your thoughts. I know that, you know, you're now trying to go after the other side of the bell curve in terms of patients with tricuspid valve disease. What would screening look like? Like, I know that depending on what your healthcare system is like, you require patients to have a certain level of assessment and follow-up. Does every patient have access to cardiologists? Does every patient get an echo in every system? How would you engineer a healthcare system that would be able to manage screening these types of patients?
I think those are really good questions, Vince. I don't know the answer to them, obviously. I mean, again, if you only see a patient when they have 4 plus or 5 plus or 6 plus or tsunamic TR, it's too late. And it's really akin to, you know, the first 20 intra-aortic balloon pumps basically went into cadaveric patients, and they thought, oh, these balloon pumps don't work. And only when we sort of came up, you know, backwards to patients who were quasi-alive, that we're going to get an impact on it. How to identify those patients is very difficult because we're not identifying those patients. Think of all the patients out there, millions of patients who are walking around with moderate to severe, and they're being treated with some Lasix and so on like that. We have to change our thinking, and it's not you and I, an interventionalist, it's primary care physicians and so on like that, to be convinced that TR is bad, that it has a mortality impact on the patients. To do that, therefore, we have to have an intervention that's innovative, that gets into the patient, and has to be very safe. Has to be very safe whatsoever. I think one of the things that MitraClip, you know, has led us, I think 10 years from now, we're going to think of MitraClip as, oh gosh, it's the only thing. We're going to look back and say, oh, that was silly. But MitraClip has become sort of like a gateway drug to other things. That it actually has shown that we can intervene on these patients who are relatively sick and not hurt them. It's very safe, to do a transeptal or, move around in the left atrium is safe. And to not do a transeptal and move around in the right atrium is super safe. Therefore, we have to have therapies that are not aimed at one end of the bell curve, but are super safe at the other end of the bell curve. I'll ask you, Peter, if you had a patient who had moderate to severe TR and we could give them a therapy very safe and it would make their TR go away, would you send your patient for that therapy? Of course you would, Peter.
Absolutely.
Now, identifying that patient is tough, Vince. I agree. Not everybody has an echo, but I think we have to sort of change our thinking, and it's beholden on us to prove to the heart failure community, to the general cardiology community, to the primary care community that we have a therapy that's safe for these patients and gets rid of TR. I don't know what that is, but I think we have to do that.
We have a lot of questions, I guess, in the queue. Sorry to interrupt, Rob. So we have one from Dr. Joel Nizik, who's one of the very busiest cardiologists in Ottawa. And his question to you, Dr. Bolling, is what about primary TR with normal RV-LV function and no mitral valve disease?
Okay, so primary TR, that's a different thing. That when I see somebody with primary TR, that raises a red flag. Because now you have to wonder, why does that patient have that? Why does that patient have that? Does he have some kind of pulmonary disease? Does he have some kind of inherent RV disease and so on like that? But again, we know that that TR is going to actually impart a mortality deficit to the patient, but you have to be very careful and work those patients up. Do they have chronic pulmonary embolism? Do they have some type of inherent lung disease and so on like that? But again, think very hard about doing something about their TR, because the alternative is if a patient with isolated TR and you say, I'm just going to medically treat this patient, they will do terribly. We all know that. They will absolutely do terribly. And even more importantly, in isolated TR, if you're going to do something, please do it upstream. Investigate them, whatever, maybe their underlying cause. Sometimes you can't figure it out. Consider intervening on those patients. But that's really is a different group of patients. Peter, don't you think? Rob, don't you think that's a different group of patients?
Yes. Yeah, absolutely. Yeah. And some of them may have, earlier, weight reduction, sort of exposure, sort of other etiologies. Absolutely. But they don't actually stay well, because they're going to get into trouble as time goes on.
Right.
Absolutely. Yeah.
Right. I mean, as we've learned in every surgical disease, in every valvular disease, we start intervening here, we learn how to do it, and it moves upstream. Think about the mitral repairs that you and I do, Vince. We do them in asymptomatic patients. We operate on them, they're fine, have a nice life, die from something else when you're 100. That's how we do it now. But it's taken us a while to move back upstream. We have to convince the general community that we can intervene on these tricuspid patients well.
Another question from our gallery is about, do you have an LV size cutoff, pressure volume cutoff that you think would predict development of TR?
That's a really good question. And people have tried to look at that. I don't know the answer to that. What we use as a criteria is 4 centimeters. If it's dilated to 4 centimeters in a 4-chamber view, with the TR and with the mitral valve and the tricuspid valve lined up, I'll do it. And that is, a rough estimate. But if you think of it, it really has been so overstretched at that point in time that it keeps on going. Remember, the data shows that in mitral valve repair, if you allow it, if you don't fix the tricuspid, you are basically, when you're there doing repair in the mitral, you are betting against your patient. You are saying, I think you're going to get TR. I'm not going to do about it. And as a surgeon, there's nothing more vexing. You were there, you were 1 centimeter from the tricuspid valve and you did nothing. That's vexing.
And a question from Dr. David Burney, one of our electrophysiologists at Heart Institute, and publishes at the New England every couple of years. His question is, any role these days for tricuspid clipping, or should we wait for better tech?
Yeah, I think we're just learning how to do tricuspid clipping. We've done, a dozen tricuspid clips. Some of them have worked really well, some have not. And some of the patients we've done sort of, drive-by tricuspid clipping. We're doing the mitral, so we do the tricuspid when we pull out. I think we're learning now. We're obviously not as sophisticated. It's not at the point where we were in mitral clipping right now. I think it's an option for these patients, but again, when the annulus gets gigantic, it's very hard, you can imagine, to pull those leaflets together and try to think that it's going to work. So I don't know the answer to that. We obviously try to clip patients and try to get a good result. It's very hard to image. Most of the time, the clip lands up between the anterior and septal. I don't know. We're not quite there yet.
And from our physiotherapy department, I love from Mark Laflamme, basically congratulating you on an excellent talk. He's interested to hear more
about what?
millipede.
Millipede.
Millipede. So, as a openness, millipede is, an idea that I founded. We sold the company to Boston about a year ago. It's basically a complete rigid ring that goes in on the mitral annulus. We only have those 2 patients with tricuspid. We have between 30 and 40 patients now out chronically. Obviously, we're iterating, and because of COVID, we've sort of every invention, every innovative company has sort of been shut down a lot. But it's interesting that it takes advantage of the mathematics of a zigzag. If you think of a zigzag going like this, a zigzag can be very, very small, so to get up a catheter, and then can be very, very big to go out and capture the mitral annulus and then come back up and pull it together. And it's actually being quite rewarding, and I think it's going to be one of the therapies that we use going forward to treat functional mitral regurgitation. I think it's going to be very interesting in the atrial FMR patients who really don't have bad ventricular disease, and it may be related to annular dilatation, related to AFib and so on like that. I think it's going to be very good. The procedure itself is very easy to do and has become relatively routine and short. If you can do a mitral clip, you can put a millipede in there. I think what we're going to see in the future is the same toolbox, say, Vince, that you and I have in. We would never go in to a surgical patient and say, I'm only going to do an Alfieri stitch. We don't do that. We have a bunch of tools. We'll say, okay, I'm going to bring the annulus down. I'm going to use that type of ring. I'm going to also do something to a leaflet. I'm going to, put a cord in it. I'm going to imbricate it or something. And then if that doesn't work, those two, I'm going to default to a replacement. I think eventually we're going to have a spectrum of tools that recreates the surgical toolbox, and it's going to recreate a percutaneous seat. That is my hope. My hope is that medical students 20 years from now say they took a saw and they did what? Yeah, I think I think that's how we're going to move forward. The problem, of course, is in degenerative disease, the standard that you and I have right now for degenerative disease is extremely high. We do it almost prophylactically, almost with no mortality and morbidity. Of course, there are some, and the patients do extremely well. It is a very high bar in degenerative disease. But I think millipede is going to be a part of this toolbox that we eventually develop.
Super fascinating. I'm going to link a couple questions. One's from Dr. Ellie Static, one of our heart failure cardiologists, and also Dr. Ian Burwash, who's one of our lead echo experts at our center. Basically, the questions from both of them really relate to, what is your proposed RV function, RV basal diameter cutoff, at which you could put your TR, when is it too late?
Yeah, so I was afraid somebody was going to ask me that, like, how do you the overall question of how you evaluate RV function? It's very difficult. Do you use RV size? Do you use TAPC? Do you use something else? We don't. I have to say we don't. I mean, it's interesting from so many studies that the RV can look terrible, say in the lung transplant population, just look absolutely terrible, and you transplant them and the RV comes back. And so we, first of all, I don't want to intervene on somebody when their RV function is dead. And the ones that I really have an RV problem with is the ones whose PA pressures are high and then they come back down. Those are the patients, stay away from them. If a patient has a PA pressure of 80, I'm okay with that. That means the RV is able to generate a lot of pressure. That's fine, it's still doing fine. It's the one where your cardiology colleagues say, oh, his RV pressure, his PA pressure was very high and now they're getting better. They're not getting better, they're getting dead. The RV is dying. Those are the ones we're very scared of and probably have to go down a different road, LVAD, RVAD, something like that. So those are the ones. And there's no specific cutoff that I can say on any RV. It's very hard to image the RV and RV function. Maybe Peter or Rob, you have a different thought about RV, but we don't have one number that we hang our hat on. But those patients who had high PA pressures and come back down, be careful with those.
I think that's true, and I think that this is exactly why Ellie and Ian asked the question, because no, I don't think any of us are really certain with those patients. But I agree, once the pressure's falling, that's a bad sign rather than a good sign.
Yeah, I mean, it's very much analogous to the LV. Is there an LV size that we won't operate or intervene or clip? Is it 65 millimeters? It's not. And it's that whole concept of proportional and disproportional MR. Are they really a different group of patients? If you look at it, it's not two circles like this. It's really an overlapping Venn diagram. And with percutaneous interventions, you almost think, okay, we're not really going to hurt this patient. Why not? So in many of the patients with bad FMR and even bad LVs, if we say, okay, you may go for an LVAD, we're starting to clip some of these patients. And of course, in some of the patients, it doesn't make any difference, but some it does. So I think percutaneously, when you have someone with a bad RV and TR, if we had a good method to get rid of their TR, then, okay, maybe you should intervene. The problem is when your intervention is not effective. So when we go take a patient to surgery with FMR, so many of the trials, left FMR. So we would do an FMR operation, but we wouldn't take it away. And then we'd say, oh, see, we can't intervene. That was terrible. Well, that's silly. That's like taking 100 patients to the OR with colon cancer and then 50% of them just leaving the cancer in and then following them for a year. You'd be very confused whether taking cancer out is a good idea. No, because half of them died. We shouldn't just take it out. If you do a terrible job, then it's very confused to answer. What you have to do is have an effective therapy, take the TR off the table and see what happens. Just like in mitral regurgitation, you have to take the MR off the table. And that may be one of the difference between COAP and mitral FRs. And COAP, they did a better job of taking it off the table.
Very interestingly portrayed. We have another question from Quan Chan, who's one of our echo experts in Ottawa. It dovetails to your comment earlier about atrialopathy. So the tricuspid annulus enlarges in AF. Does that mean we should be more aggressive in maintaining sinus rhythm?
Oh, I think so for sure. As we talked about earlier, before the talk, we looked at about 292 patients of ours who have this atrial FMR, AFMR. And these patients mostly had atrial fibrillation. We did a maze at the time, and I think we should be very aggressive. The heart likes to be in sinus rhythm. We say, we'll give this patient some beta blockers and some Coumadin, and they'll be fine. They won't be fine. They won't be fine. They'll start dilating, they'll get MR, and they'll get TR, and then you're, on the highway downhill. So I think we have to be aggressive about doing that or intervening. And again, should we operate on those patients? No, we're not going to operate on those patients earlier in their course. And maybe, we'll have some type of percutaneous intervention. Should we go on those patients and ablate them, put something in their left atrial appendage, put a ring on their mitral, put a ring on their tricuspid? Not today, but maybe tomorrow. So I think yes. And I think we have to be very sophisticated about MR. When I trained, MR was this big amorphic blob of just MR. And now we're smart enough to divide it between degenerative MR and functional mitral regurgitation. These patients over here, degenerative, have one thing wrong with them. We fix that. They have 0 things wrong with them. These patients with functional have 100 things wrong with them. We fix their MR. They still have 99 things wrong with them. So they won't do as well as the degenerative people. But I think we have to take that group of FMR patients and we have to divide them now. We have patients with atrial problems, atrial FMR, and we have patients with ventricular FMR. And these patients with atrial FMR, I think we have to be very aggressive about treating their rhythm, not letting them get MR. I think we have to intervene on them because they, I think, will do very well to do something. These people with a ventricular disease, I think we have to think of now separately. They have to be handled differently. But I think we have to be smart enough now to divide functional mitral regurgitation between AFMR and VFMR.
Another question from Dr. David Burney is, what is your approach for likely pacemaker lead induced TR?
Oh, that's a good question. I didn't talk about it today, but I think we again have to be aggressive about those patients. We see patients all the time doing well. They have a tricuspid, regurgitation because they had a pacemaker put on. The problem is surgical. Is I just looked at this data that in the STS database, the average time at which a patient has had a pacemaker and then comes to surgical intervention is 72 months. That's 6 years later. So that leaflet is now stiffened and had a bunch of TR, and they usually come with more than severe TR. Again, we're coming too late. It's very hard to repair those. You almost always have to replace them. It's like this, Vince, if I told you, hold your arm out like this for 6 years, and now you can drop it and play tennis, you would not be able to play tennis right away. And in fact, they're very, very fibrous. And so I think we have to be very aggressive. We have, a protocol of pulling the lead, maybe reverting to a leadless lead if you can. And if that doesn't work, we've clipped a few of those patients, but again, it's very hard to see how that is either, if it's perforated, it's very hard. And also it's very hard to lift that up with a clip. Some of the leaflets are just stuck down. Obviously, it's usually the septal or the posterior leaflet that is pushed like a door that's open, or it's even pinned open. And then we try to be relatively aggressive about getting back in there. The problem is if this patient's had significant TR for 6 years, they'll be difficult. The interesting study, it's hard to tell how many people have tricuspid TR from induced leads, but a Japanese study looked at 1,000 patients who had leads put in. They eliminated 400 or so. So they had about 500 patients that they followed long-term. 50 of those, or 10%, developed significant tricuspid regurgitation. So if you think of in the United States, I don't know how many pacemakers put in per year, a billion, zillion. There's a lot of patients with tricuspid regurgitation induced from pacer leads. I think we have to follow that up more closely.
That's fantastic. So I just realized here that Dr. Thierry Massana, our CEO, has logged in.
Hi, Terry. I saw you there for a second.
I think if his camera's working, I think he has a direct question for you, Dr. Bolling.
Do you hear me, guys?
Yeah, hey, Terry, we hear you.
Oh, hi, Steve. Well, thanks so much for coming virtually to Ottawa. Well, great talk. I've heard part of it a few times in meetings we were together. I think there is a very good question from Dr. Nisnik about the isolated TR. And as a comment, I would say we shouldn't underestimate enough how important it is to make sure the patient doesn't have pulmonary hypertension with TR, because actually this is a situation where fixing the TR can just kill the patient, and as opposed to make it good. Well, I had in my practice a lot of experience with doing, I was very aggressive, as you know, fixing TR routinely for mitral valve surgery. And over the years, I was still seeing some recurrence even after fixing TR. Maybe I'm not good as you are or as Dreyfus are, but I was following my patients, and I saw very intermittently, rarely it happened. So years ago, I decided to actually, because all these TRs are functional. This is the big difference with mitral. You almost don't see degenerative tricuspid regurgitation. You see all functional. So I used to do actually a combination, and Vince knows that, of a ring. It was always a partial ring, of course, with tricuspid regurgitation to avoid pacemaker, and what I call the tricuspid Alfieri. And I think it was a superior technique. And it's very, very, almost impossible to get tricuspid stenosis. Yeah. So first of all, have you done that? Second, I wonder if the solution is maybe doing a percutaneous ring and also a clip, because I agree with you. The results of clipping the tricuspid valve will be extremely disappointing. And I think we try to lie to ourselves saying, well, it's good enough if you just reduce the TR. I think it's not good enough. You have to have no or moderate TR. I think it's just a lie that we say to ourselves when you say that. Any comment? And thanks for coming again.
I agree. I think we say that to ourselves to make ourselves feel better. It doesn't make the patient feel better, but we feel better. And I mean, two things. One, your comment about isolated TR. I think we really have to think differently about functional secondary TR. Put a ring on it, fix it, do something to it. Isolated TR, like I said, whoop, that throws up a red flag that you have to make sure what's going on in their lungs, their pulmonary hypertension, something like that. Because just fixing the TR in that patient, that may not be a good idea. That's one thing. The second thing is we have done tricuspid rings with a tricuspid Alfieri. We've done like a 3-way clover leaf, which is what we usually do. Sometimes we bicuspidalize the septal and the posterior and then do an Alfieri against the anterior. That works very well. we don't have a big enough experience of doing that. I tend to do that when I thought that the RV was big and under tension. So we'd put a ring on it. And that's, I think, where we saw some recurrences, so that we wanted to do something else to hold the leaflets together. So we've done it in that case. We don't have a real way to comment on that, whether that's better or worse or something like that. But I think, again, your concept of putting a ring and a clip on tricuspid is really the way we're going to approach percutaneous, both the mitral and the tricuspid. We would, again, surgically, you and I both know that we would never go in and say, I can only do one thing. I mean, we have a lot of options there. We have a lot of things in the cupboard. We have a lot of things in our head that we can do, and we're not limited to one thing. The problem, unfortunately, right now is the way we're going to get into clinical trials with tricuspid devices is each company has one device, and they're going to say, this is the only thing you can do. I think the FDA, or in Canada, we're going to have to be smarter about thinking about, okay, I'm going to go in and I'm going to put a percutaneous ring and I'm going to clip it. That may be two different companies, but that's what's going to be the clinical practice. We're going to have to think about, are we allowed to do that? It's just like in the mitral space. Would you ever go in there and just do an alpha area? Of course you wouldn't. You know, it would have to be a rare occasion to do that. You're going to have a lot of tools at your hands that you're going to use in any combination that you think is best. And I think that is going to have to be, and we're going to have to be very sophisticated. The regulatory bodies, the companies are going to have to be sophisticated about putting all these things together best for the patient.
Anyway, I miss you, buddy.
We have one final question from our chief of cardiac anesthesia, Dr. Stefan Lambert. A multi-part question. Basically relates, congratulates you on an excellent presentation. And the question really relates on whether or not you rely on the pre-op versus the intra-op echo. So let's say you got a patient, pre-op TR is moderate, then intra-op, you got trace to mild.
Never, never turn the color on in the operating room. All right, so that's really a joke. Of course, we turn it on, but never rely on it. You've made your decision. You're going to fix the mitral valve or the tricuspid valve ahead of time. So early in my career, I would be called down to the door and then, Steve, oh my gosh, you booked this guy for a mitral and a tricuspid and he has no TR whatsoever. And I would say, great, super duper. I'll fix the mitral, but then you keep him asleep for the rest of his life. All right, because that's the only thing that's going to prevent the TR coming back. So do not rely and do not make a decision about what you're going to do in the operating room. The sort of one exception to that is if you don't have good preoperative imaging of the tricuspid, don't rely on the color, but measure the annulus. Look at the annulus size. If the annulus is dilated or the right atrium is dilated, in my mind, there's two things that can cause that. One is TR and the second one is TR. It's TR. See what I did there? They're both TR. So if you're dilated or you have a large right atrium, the guy has significant TR, fix it. But other than that, really, really try to make your decision on the preoperative. Now, of course, we look at the intraoperative, look at the anatomy, the geometry, how you're going to think about it, but don't rely on color because that patient has afterload, changes under anesthesia, and so on like that. I hope that's a good enough answer.
So the second part of that and final part of Dr. Lambert's question was, relates to what's your threshold? You come off pump, you got moderate TR.
No, no, that's not allowable. I mean, I think Thierry is right. We're fooling ourselves if, we think that's good. I mean, I usually tell our fellows that under anesthesia, whatever you see when they wake up is going to double eventually. So if you have 1+, it's going to be 2+ eventually when they're walking around. If you have 2+, it's going to be 4+. If it's going to be 0, I think that will double also. It'll be 0. Okay. So that really is, what we're aiming for. In the mitral, we do not tolerate mitral regurgitation. We come up with nothing. And then a tricuspid, I think we should have no different threshold. I think if you come off with, with squirt here, okay, fine, but certainly not moderate. And I don't even like mild. And in reality, 95% of it, what we see is functional, and some type of annuloplasty bringing it back down will basically extinguish TR. We do try to look at our zone of coaptation, both in the mitral tricuspid. If you come off and you have no zone of coaptation, as soon as that guy wakes up, he's going to have MR and TR. So measure the zone of coaptation in the operating room. But again, if you put a 28 ring on everybody, and I either put a 26 or a 28 on everybody, you're going to have a zone of coaptation and you're not going to have TR. patients say, oh my gosh, I mean, other surgeons ask me, gosh, I fixed this guy's mitral and I put a 36 on it. It looks beautiful. I did a P2 resection and then I put a 36 ring on his tricuspid and I come off with TR. And they say to me, I don't think you can fix him. And I have to be honest. I said, I don't think you can fix him either, but I can, because put a small ring on it. That's the thing. Put a small ring in. It's not really undersizing it. A 20, that's how big my tricuspid valve is. It's small. So I don't think we should tolerate. I think Thierry's right. I think we are treating ourselves and making ourselves feel better, but we're not making the patients feel better.
Very enjoyable talk. I'll defer the final comments to Dr. Beanlands and Dr. Liu. That was excellent, Dr. Bolling. Thank you so much.
Thanks, Vince. Thanks for having me again.
Steve, this has been absolutely awesome. Really, really exciting state-of-the-art talk. And I know I speak for many when we've learned a lot by you listening to you and your experience. So we're really, really grateful for you to come. And I know you're going to be spending a little bit of time with the residents and fellows. So we appreciate your time with that as well. So on behalf of everybody here at the Heart Institute and across Canada who've joined, thank you for your time. And I don't know if you can see that. There it is. Oh,
Go blue.
Go blue. There we go.
Go blue. There you go. We're having an off year, but everybody's having an off year this year.
Okay.
Yes. All right. Yeah,
Peter.
thank you so much. Yeah, so really appreciate it. And this being a star performance as always. And what you say, for our heart failure patients that we see is so true, because it really reflects exactly what we see, in the front lines, and all those solutions you talk about, really, to me, it's very inspiring. Now I'm going to have a more serious conversation with my patients to get them. Absolutely.
Well,
Thank
Peter, Rob, and Vince and Terry and everybody on the line, thank you very much for virtually having me in Ottawa. Sometime in the future, I'd like to come up there. Really, it's been a great pleasure. Thanks very much. Okay, see you guys.
Yeah.
Bye now.
Bye-bye.